Hey, this is Brad from our Tactical Medical Training. So we're going to talk about ketamine a little bit more because ketamine is a great drug. Does a lot of good things for us, but like any other medication out there, ketamine is not absolutely safe or absolutely indicated for every single patient. We need to understand when we're giving ketamine and why we're giving ketamine. And what's that effect going to have on our patient? Can it increase our patient's blood pressure? Absolutely, it can increase our patient's blood pressure. But what we don't talk about often is the patient's blood pressure that can be decreased by ketamine. So we're going to talk about that, as well as dispel a few myths out there about ketamine as well. So probably one of the biggest myths that kind of got started back in the 70s was, hey, is ketamine okay for head injuries? And it was actually studied in 1972 in British Journal of Anesthesia, published an article in 1972 that talks about, I'll pop it up on the screen here for you too so you can see it. They talk about increased intracranial pressure in pediatric patients. Well, the study population was 5 patients. Really big study group, 5 freaking patients, right? But on 9 occasions when they gave those 5 patients ketamine, they had increased levels of intracranial pressure. Well, those patients weren't trauma patients. They were children who had like increased levels of cerebral spinal fluid or like glioblastomas or other kind of brain tumors or something like that. So yes, on those type of patients, then ketamine does increase intracranial pressure and is not indicated. But they extrapolated from those 5 patients that, I'm just going to read it word for word. Clinically, this situation may be manifest not only in neurological patients, but also in recently traumatized children with possible head injuries undergoing minimal or orthopedic procedures with ketamine as the anesthetic. So that was a pretty big leap without a large study group to say, hey, ketamine can increase intracranial pressure. So for the next 30 years, we said, oh my God, don't give ketamine to anybody with a head injury because it can make their head injury worse and increase their intracranial pressure. So actually what we found out was that wasn't true. So around 2014, 2015, some more studies started coming out saying, we might have missed the boat on this one. We kind of may have misrepresented ketamine in our TBI population, true patients with TBI. I'll pop up another references here, talk about different publications from American Emergency Medicine, Australasia, EMA, as well as Neurocritical Care, and even the Journal of Neurosurgical Pediatrics talks about effectiveness of ketamine and decreasing intracranial pressure with children with intracranial hypertension. So actually, a lot of these studies are showing that patients who receive ketamine during TBI, that ketamine may actually be neuroprotective for those patients. So we pretty much debunked that whole ketamine is bad for TBI and causes increased intracranial pressure, right? So, and some more current data right here from Critical Care, published in January 2021, says ketamine might be considered as a potential drug to optimize analgesia and sedation in the management of mechanically ventilated patients with severe TBI in association with other sedative agents. So ketamine kind of getting a little bit more acceptance, right? And more use for TBI and just general use overall, right? But with everything good, there can be bad, right? So let's talk about this article that got published in March 2021 from the Academy of Emergency Medicine in Australia. They actually talked about the association of ketamine induction with blood pressure changes and paramedic rapid sequence intubation of out-of-hospital traumatic brain injury. So what that really means is they studied thousands of patients in 2015 when those studies started coming out about ketamine's okay for head injury. Well, they kind of changed their protocols for their paramedics in Australia. So now that's paramedics who are way out and have a long transport time to get patients in, and paramedics who are maybe not as further out, but were able to ground transport within 30 to 45 minutes. So large population, and what they found was some of those patients were developing hypotension after receiving ketamine. Well, is it the ketamine's fault, or is it they also concomitantly or at the same time administered morphine and Versed, which we know can drop blood pressure as well? Was it also the addition of positive pressure ventilation with positive and expiratory pressure, which can also increase interthoracic pressure and decrease preload coming into the heart? And if we decrease preload, then we decrease cardiac output. So could that be a reason for it as well? the study said, they say in the study that they took those into account and still saw that there was a decrease in blood pressure. So physiologically, why is that? Because we've been told our whole lives that ketamine's a beta-1 and beta-2 agonist, increases blood pressure, increases bronchodilation, which is a good thing for trauma patients. And that's true. However, the body will only compensate for a set period of time, and then it's going to stop compensating. So let's dive into that a little bit more. Right? So let's investigate why is it happening, and we're going to use this semi-permeable membrane that I drew out here. So let's talk about it a little bit more. So we know that ketamine is. I'll grab my pen here. We know that ketamine affects the NMDA receptor site. It blocks the release of the neurotransmitter glutamate so that those nerve impulses are not recognized in the central nervous system and increases sedation and provides that dissociative effect, right? So ketamine, I'm not a very good artist, so you're just going to have to work with me here. That's not a very good pen. Let me get a better one. I have a better one. All right, so ketamine comes in here, attaches to this receptor site here, ketamine, all right, and that gives us our dissociative effect, right? But also ketamine can attach to, we think attaches to the opioid and muscarinic receptor sites as well. Well, those are part of our parasympathetic nervous system, right? So parasympathetic nervous system, which is not our fight and flight response for the sympathetic nervous system, but it's our rest and digest, right? So it's the opposite of the sympathetic nervous system. So if ketamine can attach to these sites here, all right, I'm just going to abbreviate that KET so it's a little bit quicker. All right, if it can attach to those receptor sites there, then that should decrease blood pressure. So then we should always get a decreased blood pressure effect when we give ketamine, right? That's not what happens though, because in addition to that, we have these sympathetic receptor sites and the catecholamine reuptake channels. So what happens is the body's under stress, it releases catecholamines like epinephrine and norepinephrine, generally about 80% more epinephrine than norepinephrine, right? So in general, so those epinephrine can come down and bind to those little receptor sites there as well, right? So a little epi right there, we get a little norepi attached right here, right? And some of those also get onto the catecholamine reuptake channel. When they go to the catecholamine reuptake channel, they get back into circulation and they do their thing, right? So because the sympathetic receptors are being stimulated, they're stimulating the sympathetic nervous system, right? That has a higher response than the parasympathetic nervous system as it overrides that parasympathetic nervous system, which means that your patient's gonna have an elevation in blood pressure, elevation in heart rate. Pretty normal response there, right? So what ketamine also does when we give ketamine is it blocks this catecholamine reuptake channel right here, right? So ketamine blocks that. So if it's blocking it, then these other catecholamines that are floating around can't go through that catecholamine reuptake channel, so they'll attach to other receptor sites, right? And even increase it even more. So that's why we generally get an increase in our sympathetic nervous system, increase in heart rate, increase in blood pressure, as normal with ketamine, right? Now, what happens if our patient's under stress? If our patient's under stress because they're in hemorrhagic shock or they're in sepsis or something like that, something where the sympathetic nervous system's been being just bombarded continuously by epinephrine and norepinephrine, and maybe those receptor sites are getting a little wore out after a while, a little bit stressed, then because this is blocking this here and there's no more reuptake happening, then basically there's less and less floating catecholamines around. These things all start disappearing, right? And maybe there's not enough to attach to certain receptor sites, right? So much so that now the parasympathetic nervous system is taking more control over the body than the sympathetic nervous system, and therefore you get that parasympathetic nervous system response, which is a decrease in blood pressure. So that's how ketamine can decrease blood pressure in a patient, right? So does it happen all the time? Not always, right? But patients who are just continually being bombarded with catecholamines that are being released and their receptors are just getting stressed and overused and basically overused, they're not going to respond as well as they did before. So does that mean that every patient who's in hemorrhagic shock should not receive ketamine? No. Sometimes patients who are in hemorrhagic shock will benefit from ketamine because they'll get that initial sympathetic nervous system response because their catecholamine receptors are active and still and not too stressed yet, right? But over time, especially in someone who's in sepsis, over time those catecholamines are not going to be present, which is why we give patients in sepsis like epinephrine or norepinephrine, push dose epi or norepinephrine to help bring their blood pressure up because their catecholamines are not present because they would have been worn out. So, so hopefully that explains a little bit for you. There's tons of other videos out there on YouTube. Take a look at some of those different sites if you really geek out on the physiology behind it. Ketamine again is a great drug, a great medication, can be helpful for you, but not every time, not every drug is always going to be without its risk, right? And one of the risks of ketamine is it can cause hypotension as well as hypertension. So now the study that we talked about with ketamine inducing hypotension in TBI patients in Australia, one of the things in their study, they talked about the average decrease in systolic blood pressure was 7.8 millimeters of mercury, right, initially. And then it started increasing by 0.5 millimeters of mercury over the study period, which was like a 7-year study period, right? Is 7.8 millimeters of mercury really significant? All right, they said a 5% risk, 5% increase, right? So is 5% statistically significant, right? I would argue that maybe not. If my patient's blood pressure is 120 over 80, which how many patients in shock have a blood pressure 120 over 80? Probably a fair amount in the early stages of shock. It's not until stage 2 or stage 3 that we start seeing a decrease in systolic pressure and a narrowing of pulse pressure anyway. So if my patient's blood pressure drops from 120 systolic to 110 systolic, I'm not really too worried about that, right? And give them a little bit of fluid bolus. If they need blood, they need blood, right? If they're in hemorrhagic shock, they need blood to fix that. Clear fluids is not going to fix that. Blood is going to fix that. But if their systolic's 110, I'm okay with that. But if my systolic pressure's, I don't have a radial pulse, so the systolic pressure is probably less than 80, then I might be a little bit more concerned of a 10 millimeters of mercury drop in systolic pressure, right? So just keep that in mind. Hope that helps. If you have any questions, feel free to shoot me a message. Like the site, like my YouTube channel, and I'll try to get more videos out there as we can. Everybody have a great time. Later.